Good morning, everyone. Good afternoon, good evening. A very warm welcome to this launch webinar for the community on non-communicable diseases. We have so many of you join us today. We've got a great lineup for you. My name is Emma Feeney. I'm the Senior Advocacy Advisor at the George Institute for Global Health, and I'll just be giving you a very quick overview of the format of the webinar before we move on to our speakers. So in a minute, we'll be starting with Guy Fones, who's head of the Global Coordination Mechanism on NCDs at the World Health Organization, and he'll be giving us a knowledge action platform and explaining the communities for those who aren't familiar with them. We're then going to hear from Professor Robin Norton, who's our Principal Director at the George Institute, and she's going to introduce the community itself and talk about what we're hoping that we can all achieve together through the community. We'll then hand over to our moderator for today, who is Shanti Mendes, consultant in global health and a former senior advisor to the World Health Organization on NCDs, and she will be moderating our speakers and the discussion that follows. So we'll have 8 5-minute presentations from a panel on a range of different issues, all related to the question, why focus on women and non-communicable diseases? And after that, we'll be taking questions for about half an hour at the end. So please do get involved, type your questions in the chat box as we go along, and we'll try and get through as many of those as we can during the discussion. Any questions that aren't answered during the course of the webinar will be online discussion on the community for discussion after today. The consultation online will be going on for about 10 days, so do please post your questions and we'll make sure we get to them, if not today, then in the online discussion afterwards. So I think that's all I need to tell you at this point, and perhaps we can hand over now to Guy at the World Health Organization.
Can you speak now?
Hello, good morning, Emma. Sorry to come in. Can you hear us? Can you hear us, Emma? Yes, you can. I do apologize because from our end, and it seems to just be us, we cannot hear the speakers at this moment, but we will try to fix that. I hope you can hear me well. And I think, Emma, you have been giving me the floor. Okay, great, excellent. So I will take the floor. Thanks so much. First of all, on behalf of WHO's Global Coordination Mechanism on NCDs, I am Guy Fones, acting head for the GCM, and I am extremely pleased to welcome all of the engaged participants we have online currently, and I see that the numbers are growing as we speak. We are excited that we already have 100 participants, and I'm sure more will come on as we move on. Extremely excited to have all these participants for the launch of the exciting initiative on the community on women and NCDs. I'm also particularly honored to welcome such an esteemed panel and moderator, and look forward to all of your insights on why it is so critical that we draw attention to women and NCDs. In particular, at a moment when the global NCD community tries to identify the trigger points and overcome some essential bottlenecks that will ensure that we leave no one behind when addressing NCDs and mental health conditions. I'm sure many of the panels will touch on some of these aspects, but as we all know, and I think we all understand, women and girls experience persistent gender, social, and economic inequalities, which increase their vulnerability and affect every aspect of their lives, including their health. A better understanding of how these factors shape women's experience of NCDs and injuries is essential for the achievement of our lighthouse goal, SDG target 3.4 on NCDs, which states that by 2030, we hope to reduce by 1/3 premature mortality from NCDs through prevention and treatment and promote mental health and well-being with the overarching principle of leaving no one behind. So this initiative, let me state very clearly, would not have been possible without our strategic partner and community facilitator, the Georgia Institute for Global Health. Our gratitude to the leadership and support. The aim of the community, as you may have already read and understood by the information we have provided, is to facilitate knowledge and exchange and dissemination among key stakeholders interested in promoting evidence-based, scalable best practices when implementing a life course approach to women's health and NCDs. This overarching aim is precisely why this new community will join a very healthy portfolio of communities hosted on WHO's recently launched Knowledge Action Portal. We will facilitate and support, from our end, the WHO Global Coordination Mechanism, a cross-fertilization among these communities, an interaction, a communication, a knowledge sharing among these many communities, such as health literacy on NCDs, NCDs and the next generation, multi-sectoral actions on NCDs, NCD and the commercial determinants of health, the meaningful involvement of people living with NCDs, NCDs, poverty and development, NCDs, health and law, and a community of practice which convenes all national NCD focal points at country level. So this is really an exciting opportunity to understand the many aspects that drive, impact, and challenge the NCD agenda. And by allowing these communities to be fertile and healthy and interactive on the recently launched CAP, we will ensure that this cross-fertilization, the interactions, the connections between these different communities, constituencies, and stakeholders can drive the NCD agenda with a bit more of a accelerated focus and strategic actions. Let me just a few words on the Knowledge Action Portal. Recently launched by WHO through the Global Coordination Mechanism, we have tried to launch and to implement one of the pillars of the GCM's mandate, which is knowledge dissemination, facilitation of engagement of stakeholders, and identifying innovative solutions and actions for NCDs. We have created a community of connected individuals from various backgrounds and skill sets, as you see on the slide, providing a centralized point for accessing knowledge and information, promoting collaboration, and empowering global, regional, and national and local action on NCDs. We urge you to visit the CAP if you have not already done so, visit your community, which you are participating in now, but also understand that you have the ability, the support from the GCM to interact with additional communities, stakeholders across the CAP, not only in communities, but also access country pages, country progress on NCDs, country information on best practices, success stories. We will soon launch a research tool which will facilitate interaction within the research community. So as you see, it's a very, very healthy, active, engaging, interactive, and informative CAP, where these communities will be a central focal point for accessing these underserved pockets, these enabling factors for the NCD action. So this is my overall introduction. I am extremely pleased to welcome this new community to the family, into the CAP. I hope that the members who are participating in the webinar today will have access to the CAP soon, register, and take advantage of the many interactive knowledge sources, resources, and interactive, engaging activities that we will launch on the CAP shortly. So without further ado, I will pass the floor to Robin Norton. And thank you, Professor Norton, co-founder and principal director of the Georgia Institute for Global Health. We look forward to your comments on the introduction to this community. Thank you so much.
Hi, this is Emma at the George Institute. Unfortunately, Robin has been trying to log in and hasn't been able to. So I'm still hoping that she might be able to join us. But in the meantime, I will present some remarks on her behalf. First of all, I'd like to start by just saying how delighted the George Institute is to be facilitating this community with WHO's mechanism, and huge thanks to them for all their support with getting this up and running. It's been fantastic working with you. The George Institute, as many of you may know already, has a very strong focus on women's health and non-communicable diseases. We have a global women's health program that was established in the last couple of years, which is expanding rapidly. We are particularly interested in issues such as sex differences and gender disparities in health. We have a growing research program looking at big data sets and examining risk factors and so on for women and men, and many of you will have seen some of the papers, I hope. We also have a focus on integrating the management of pregnancy and prevention of NCDs and injuries, as well as more specific issues such as women as healthcare workers, gender-based violence, gynecological cancers, and so on. When this opportunity came up for us to get involved in this community, we were really excited and very keen to join. So what we're hoping that this community can do is to bring together diverse global experts from the fields of women's health, but also beyond. And obviously the huge registration we've had for today's webinar is a very good sign. It's great to see that there's so much enthusiasm for this. And I think a lot of people feel that this really is something that we need to be focusing on more. And we hope that this community will enable us to create a network of people who are interested in promoting an evidence-based, scalable best practices around implementing a life course approach to women's health and NCDs. And it will also support members of this community to implement those best practices. And by doing so, as Guy was saying, the end goal has to be to support progress towards the targets set out in the global and the Sustainable Development Goals. So that's what we're hoping to achieve over the next months and years. And just to add that we have an amazing steering group guiding the work of this community. In addition to the speakers you're going to hear from in a minute, this group also includes Dr. Rilwan Adan, who's head of the Diabetes Care Centre at Lions Hospitals in Kenya, and also Chief Medical Officer at Baobab Circle. It includes Hill, who is NCD consultant at the Ministry of Health and Prevention in the United Arab Emirates, and who is also a former WHO regional. We have Maisha Hutton, who is the Executive Director at the Healthy Caribbean Coalition, which is an alliance of over 100 civil society organisations based in Barbados. We have Dr. Ricky Liu, Director of Family Planning and Reproductive Health and Cervical Cancer Prevention at JPIGO. And we have Dr. Lin Hong Wang, Director for Chronic and NCD Control and Prevention in China. And as I say, those are just in addition to the speakers you're going to hear from shortly. So as you can see, a huge range of experience and expertise from all around the world. So we're very grateful to all of our steering group members for working with us on this. I just wanted to say that this is the first of a number of webinars. So we'll be looking at a whole range of issues as we go along. These are likely to include things like maternal health, gender analyses of disaggregated data, violence against women, and potentially many other issues. And we will, of course, be looking for your input, so do please get involved in the discussions online on the community and help to really shape what we do going forward. So Robin and a number of other people from the George will be attending the Commission on the Status of Women in New York in a couple of weeks' time. Going to be co-hosting an event with the WHO, the NCD Alliance, the Task Force on Women and NCDs, of which we're a member, and Thailand and Uruguay. The event will be focusing on women and NCDs and universal health coverage. But Robin will be presenting this community at that event, and she'll be doing her best to convey all the key messages we have from the discussion here today at that meeting. So do please get insights. So apologies again that Robin wasn't able to deliver the introduction herself. I know that she's still trying to get into the meeting. But at this point, in the interest of time, it's probably best if I hand over to Shanti, who can begin moderating our panel of experts. So Shanti, if you're ready, that would be great.
Thank you, Emma. A warm welcome to all. Why focus on non-communicable diseases and women? Every year, more than 20 million women die of heart attacks, strokes, cancer, diabetes, and other NCD conditions. As you heard from Guy and Emma, today an eminent panel of speakers will use a gender lens to analyze this subject. As the moderator, first, let me give you my take on the issue. You have joined this discussion because you are passionate about this subject and because you are against discrimination based on gender. All over the world, women experience more discrimination than men. Personally, I have experienced discrimination based on sex, as well as race and color. Globally, millions more women than men experience poverty, hunger, difficulties with schooling, and unemployment. Women hold just 24% of parliamentary seats in the world, and among owners of agricultural land, only 13% are women. Discrimination of all forms is unacceptable. It is against human rights. Discrimination based on sex make women more vulnerable to NCDs, and women also face more barriers than men when accessing healthcare. There are at least two other reasons why we need to focus on women and NCDs. NCDs during pregnancy are a neglected issue. Women are also caregivers, health workers, so they are key partners in our fight against NCDs. So let us get started, and our speakers will elaborate more on all of these issues. First speaker is Dr. Anne Keeling. I would like to invite Dr. Anne Keeling. She is Senior Fellow at Women in Global Health, Chief Executive Officer of the International Diabetes Federation, and founder of the NCD Alliance. Floor is open for you, Dr. Keeling.
Thank you, Shanti. I just want to check that everyone can hear me.
We can.
You can, okay. And just to say that I'm not a doctor. I wouldn't let me near any patient whatsoever. It would be a very dangerous thing to do. But thank you, everybody. I'd like to outline 10 myths and misconceptions on women and NCDs, and then hand over to my expert colleagues to elaborate on those issues. So there they are, they're on the screen. Number one, biological sex doesn't impact on NCD prevalence. Yes, it does. Right down to men and women having different sex-specific NCDs, for example, ovarian and prostate cancers. So we need health systems that disaggregate between men and women. Point number two, gender determinants of health don't impact NCD risk. Yes, they do in a hugely important way. Shanti's spoken about gender inequality, gendered roles, and gender roles in society drive NCD risk. For example, women are more likely to get lung cancer from indoor cooking stoves, and men are more likely to get lung cancer from tobacco use. We can't understand NCD risk without understanding gender determinants of health for that context. Point number three, all women are the same. No need to look at intersectionality. Wrong again. Women are not a homogenous group. they can be divided into races, ethnicities, so many different ways of dividing women in important ways for their health. For example, South Asian women have a higher risk of type 2 diabetes than Caucasian women, and so advice on prevention is different. We need health systems that treat all women with dignity and respect, including trans women and women from marginalised social groups. Again, point number 4, all women are the same. No need to consider the life course. Women have very different needs and priorities throughout the life course when it comes to NCDs, and others of my colleagues will be talking about that. Point number 5, one size fits all. We can test drugs on men and they'll just work for women. In health, we can't take men as the norm and treat women as just abnormal men. Drugs tested on men won't necessarily work the same way on women, and we've seen that very clearly in cardiovascular disease. My point number 6 is, again, one size fits all. Women have the same NCD symptoms as men. Not true. So when it comes to prevention, again, we can't treat women as abnormal men. Cardiac arrest symptoms, for example, are very different in women, but male symptoms are typically treated as the norm in prevention and diagnosis, and many women die as a result. Point number 7 is about affordability. Household income is generally treated as the most common measure of income, but it masks differences in income within the household between men and women. And so it's not a good indicator of what's affordable for women in terms of health services, critical for universal health coverage. Point number 8, women, especially in low-income countries, have lots of free time. This, I think, is one of the biggest myths of all. Women and girls, particularly in low-income countries, but just about everywhere, shoulder the majority of unpaid health and social care. It's often unrecorded, it's usually uncounted, and yet we see programs all over the world engaging women as unpaid community health workers and health promoters. Number 9, gender inequality in the health workforce is irrelevant for NCDs. Wrong again. Women are 70% of the health workforce, and that's probably an even higher level in most countries at primary healthcare, which is the critical level of healthcare for NCDs. Yet women are segregated into lower status, lower paid roles. We're losing female talent and perspectives in health design and delivery from community and global. And I'd like to make a special point about including women with NCDs in decision making. Point number 10, final point, health and nutrition of mothers is unconnected to NCD risk. Not at all. Maternal health and nutrition has a critical impact on NCD risk for the unborn child. NCD prevention starts before birth. And I think that's 10 great reasons why gender equality in health is everybody's business, and 10 great reasons why we're having this discussion today. Thank you.
Thank you very much, Anne. The next speaker is Professor Alan White, Emeritus Professor of Men's Health, Leeds Beckett University, the United Kingdom. Professor White, please.
Thank you for inviting me to speak today. We have here two bodies. I can't see the picture. There we are. We have here two bodies, that of a younger male and an older female. The bodies are stripped back to reveal their organs, but we retain a sense of the total person. This allows us to consider the raft of complexity that exists as a person lives their life with the influence of intersectional factors and the impact of social determinants and social cultural life ways being covered by others in this webinar. My focus, however, is on what's happening under the skin. And we have two sets of knowledge to contend with. That of the relatively well-known male body and the mostly unknown female body. Most biomedical research has been focused onto the young male body, of about 70 kilograms and mostly Caucasian. This has created one model, anatomically, physiologically, metabolically, pharmacologically, with the false expectation that this could then be extrapolated to the female, and also to older men, men of different races, etc. So we see the older female as at risk of many different non-communicable diseases, but the underlying pathways and mechanisms in play, the diagnostics required to identify the problem, and then the therapeutics required to treat the conditions, are all understudied and now only starting to be revealed. Sex differences start at the cellular level, with the genetic impact of being born with XX as opposed to XY chromosome. But this talk is not on the hugely complex biology of the female reproductive system and the impact of motherhood, but on the wider implication of these chromosomes across the body. This includes, for instance, the sex hormones, which have a great impact on women's risk of NCDs, as they have an influence on nearly all aspects of bodily function, from the enhanced immune system to fat deposition, through to exerting epigenetic changes such as DNA, acetylation and methylation. So if we come up to see what we can see on this slide, women's lungs are smaller, with smaller airways, and they're more likely to develop chronic obstructive airways disease at a lower dosage of exposure to tobacco. The female sex hormones impacting on allergic responses in the airway increases the risk of asthma in women post-puberty. Following the menopause, there's an increase in new onset asthma attacks in other respiratory systems, irrespective of smoking habits, thought to be a result of hormonal changes affecting the immune system within the lungs, increasing inflammation of the airways. Women are more likely to develop a different form of lung cancer to men, adenocarcinoma, which develops in the outer regions of the lungs. These don't have the same effect of coughing as the male type, and therefore tend to be more advanced before being identified. Women are also more likely to experience fatigue, shortness of breath, or chest or back pain due to metastatic spread. Women are more likely to develop a different form of bowel cancer. The female sex is more associated with hypermethylation, microsatellite instability, and other genetic factors, which are more likely to result in the sessile serrated polyps forming in the proximal colon, with lower levels of hemoglobin in the feces and not picked up on flexible sigmoidoscopy, so harder to detect. This form of cancer also tends to be more aggressive. Women's hearts are smaller than males, but the differences go much deeper than size, with differences in epidemiology, clinical manifestation, pathophysiology, treatment and outcomes being seen between men and women. Many of these sex differences are under-recognized within the medical community and by women themselves, leaving them vulnerable to misdiagnosis and appropriate treatment. Aspirin is one example, which has been long used in reducing cardiac risk, but research now shows that it's mostly ineffective in women, whereas it has more beneficial use in preventing stroke than in men. The GenCAD project created very useful guidance for both practitioners and for women. Women process alcohol at a slower rate due to having less body mass, more fat, and a lower body water content, which leads to a higher concentration in their body and alcohol staying in a woman's system longer before being metabolized than it does in a man's. In addition, women generally have lower levels of alcohol dehydrogenase, which is needed to metabolize the alcohol. And interestingly, women slip more quickly into addiction than men. Thankfully, we are seeing big changes in the way that science now recognizes sex and gender differences. We are seeing funding bodies only considering studies that are appropriately powered to show the impact of sex and gender. Journals are also playing their part as they exert editorial control over papers that still fail to provide sex disaggregation. However, this is just the tip of a learning curve in relation to understanding the relationship women and men have with non-communicable diseases, but hopefully gives us an insight into the task ahead. Thank you.
Thank you, Dr. White, Professor White, for your presentation. The next presentation is by Dr. Nahid Tubia. She is Director, Institute for Reproductive Health and Rights from Sudan. Over to you, Dr. Tubia.
Hello, thank you, Shanti. Hello, everybody. I would like to make a disclaimer at the beginning. I have studied in Egypt. I'm a medical doctor and I specialized in England, and I practiced in all these countries plus Sudan. And I have to admit that my sensitivity to NCDs in women was not very high. So while I joined this group and tried to bring in my contribution in the intersection between reproductive health and women's NCDs, I look forward to learning and I look forward to learning and also sensitizing myself and others about these issues. With regards to how I start thinking about it, I would like to introduce two aspects plus which are the human rights or the rights to health, as well as the culture's differentials that affect women. Of course, there are physiological, anatomical, hormonal, and other differences, as the previous speaker has just told us. But I want to start with the idea that a woman with NCD, whatever the reason for this NCD, whether childhood diabetes, some kind of early onset hypertension, cancer, even genetic diseases, even mental health, as the introductions have told us, these women have the right to be pregnant and have children. We have very little knowledge and services to how to help these women exercise their rights to having families and particularly having children, and with the appropriate care that takes into consideration their special needs. I personally have friends who had great difficulties getting pregnant because they have severe childhood diabetes. So there is that regional issue. Let's not forget that women have the right to make these choices, despite the fact that they may have physical or mental non-communicable diseases. As mentioned by the introductions, there is also long-term care for women who develop NCDs during pregnancy. We are, of course, all aware of diabetes and hypertension during pregnancies, maybe other conditions, including postpartum depression, and we don't know whether it has any long-term lasting effects, and maybe other conditions. We talk about their treatment during pregnancy, but the systems, particularly in developing countries, don't necessarily connect these women to long-term care. The household and childcare responsibility do affect women's inability to manage their NCDs. Two of our previous speakers spoke about the economics of gender within the household, but also the responsibility of women taking care of children and how that curtails their ability to take care of themselves, whether it has to do with nutrition or has to do with medication or accessing healthcare due to a range of barriers, whether it's distance, finance, quality of the service itself. I want to talk about menopausal women within the reproductive health spectrum, because NCDs are not treated only by medication and by biochemistry. I think we all know that many aspects of NCDs are now reliant on changing lifestyle or acquiring a healthier lifestyle. Healthier lifestyles are expensive, particularly for poor women. But even if we talk about all women, I hope we're not only talking about poor. We talk about poor, middle income, maybe even those who have access to some more resources. There are sometimes, apart from the financial barriers, the environmental barriers, poor women in slums don't have much chance of changing their lifestyle, whether it's nutrition, exercise, sleep, relaxation, and other aspects of managing NCDs through a healthy lifestyle. But also there is cultural barriers. Women over 45, in at least some of the cultures that I'm aware of, sometimes don't have that access. They can't go out and exercise in open spaces. There are pressures on them to participate in nutrition in a particular ways. I don't want to go into a lot of details. I'm sure we can look into these details. But there are cultural barriers to the change in lifestyle that women, especially at menopause, may not be able. And these are the women, of course, more likely to develop some of the long-term NCDs. Reproductive oncology is a whole big field which again is not being attended to appropriately, particularly within prevention and particularly with poorer environments. Although we know now that there is more and more cancer, even in developing countries, particularly with women who are more exposed to carcinogenics, with very little early detection and treatment. These are just broad outlines of the kinds of areas that we can look into a bit more carefully when we want to look at that overlap between the reproductive cycle. And I'm sure there is much more. I'm just touching, very quickly on the broad areas. Thank you very much.
Thank you, Dr. Tubia, for sharing your insights. Dr. Caroline Homer will give the next presentation. She is Co-Program Director, Maternal and Child Health, Burnett Institute, and Visiting Professor of Midwifery at the University of Technology, Sydney, Australia. Dr. Homer, floor is yours.
Thank you. Thank you, Shanti, and good evening, good morning to everybody around the world. So my talk, my 5 minutes, goes on quite nicely from Nahid's discussion. Particularly, I'm going to focus on the women who develop NCDs during pregnancy. We know that what happens during pregnancy makes a big difference to the children over time, and I'm not going to focus particularly on that, but of course that's important. Nahid also mentioned two very important NCDs, or conditions that women develop in pregnancy, and we now know have long-term implications. So for those of you who work in maternal health, you'll know that preeclampsia, the condition that includes hypertension and a number of other organ dysfunctions, is one of the top 5 causes of maternal death, but it's also one of the main causes of morbidity. So women around the world, the incidence of hypertension in pregnancy is about 1 in 10 pregnancies. About half of those are preeclampsia, which is the nasty type of hypertension in pregnancy. And this is responsible, as I said, for considerable mortality and morbidity around the world. Over the last decade or two, we've become very good at developing guidelines of how to care for women while they're pregnant, who have hypertension in pregnancy or preeclampsia. But we've been very poor at developing guidelines or even the evidence about what happens afterwards. And mostly as clinicians, I'm a midwife, mostly we tell women that once their pregnancy is over, 2 or 3 months later, their blood pressure will go back to normal and it'll all be fine. It may come back with their next pregnancy, but very rarely do we have conversations with women about long-term effects and their long-term risks of NCDs. We know there are long-term effects and long-term implications for women. That chronic hypertension is more likely if women have had preeclampsia, particularly if they've had preterm preeclampsia. They're more likely to get premature cardiovascular disease some 10 or 15 years earlier than women who didn't have preeclampsia in pregnancy. And those risks remain when adjusted for women with many traditional cardiovascular risk factors. So having preeclampsia or a condition in pregnancy related to hypertension adds to your risk of long-term effects. And this is made even poorer or more significant if you have diabetes. So there are a number of theories around this. One is that pregnancy is a stress test for life. And I think many of us would agree with that just generally. Women bring risk factors into their pregnancy, and they may fail that stress test of pregnancy in terms of their cardiovascular health. And this is carried into later life. There's also a theory that it's the other way around, that having hypertensive disorders of pregnancy permanently and unfavorably alters a woman's vasculature to long-term cardiovascular risk. Regardless of whether it's chicken and egg, it's a major public health problem, and currently know that it's not incorporated into cardiovascular assessments in many countries. Many clinicians, when they're seeing women in their 50s and 60s, ask whether they had preeclampsia or hypertension in pregnancy, and it's not well recognized. In my last minute, just briefly around national diabetes, because this is becoming a very significant around the world in low, middle and high income countries. This infographic comes from Women from International Diabetes Federation and FIGO, and highlights the long-term implications of gestational diabetes. We know it's on the rise, we know it has complications for the baby, but it's also complications for women long-term, more likely to get diabetes, more likely to get high blood pressure, both for themselves and for their children in the future. So in summary, I think we've become quite good at managing these conditions in pregnancy, and certainly these ones and others, perhaps like mental health conditions in pregnancy and the early postpartum period, we've become better at. But we're not good at discussing long-term risks with women. We're not good at knowing what to say to women after they have these conditions, and we need more research identifying what is the best thing for women going forward, and how we can make sure that not only after they've had their baby they're healthy, but a whole other area is preconception. So making sure women go into pregnancy in the best possible health so that they'll end pregnancy in the best possible health. Thank you, Shanti.
Thank you very much, Caroline, for elaborating on the links between maternal health and NCDs. The next presentation is by Dr. Isabel Yodi Aguirre. She is head Gender and Health Team at the World Health Organization European Office in Denmark. Isabel, the floor is yours.
Thank you very much, and good morning, good afternoon, everyone. I also want to clarify that I'm not a doctor, but I want to present a little bit the work that we have been doing in the European region for WHO, which actually covers 53 countries, all the way to the former Soviet republics, the Central Asian republics as well. And this is the two strategies we have on women's and men's health, which are accompanied by two pieces of evidence that inform the recommendations of these strategies. And the reason why I want to present this work is because this was a very strong alliance between the NCDs community in WHO in the European region and the gender and human rights community. And both strategies and report have a strong focus on looking at NCDs as the main burden of disease and mortality for both men and women in the European region. One of the key issues that we address both in the reports and the strategies is using that life course approach and how the social determinants of health had a differential impact across the different life stages, but also in men and women. And when we look at women and the impact of the social determinants of health, and we look at for instance, the fact that the same determinant like education does not have the same impact on NCD's risk factor on men and women. We see that, for instance, education has a bigger impact on tobacco use among women than among men. And it depends also in the country that we are talking about in terms of the development of the tobacco epidemic. So countries where women have been smoking for a long time is mostly associated with a lower socioeconomic status, like while in countries where the epidemic is newer, it's women that have a more affluent socioeconomic status. If we take, for instance, the example of diabetes, we see that for men and women, a low income and low education, women and men are more likely to develop diabetes. However, women with low educations have higher mortality rates than men with the same level of education. So the points that we want to make both in the reports and the strategies that inform actions is that the impact of the same determinants may be differential in terms of the gender norms that drive masculinities and femininities and the different norms and roles that are in society. There are some correlation that works similarly, like the correlation between education and alcohol-related mortality for both men and women. But there are some specific areas where it's not only the low health literacy levels, but also the link with migration status, belonging to an ethnic minority, where we see examples of the success stories of the breast cancer and cervical cancer screening policies. So that's one of the main messages. The other message is that when we work with social protection policies, and we also look at the analysis of how social protection policies may encourage or perpetuate some of the gender divide that it is in society. We do know that the wage gap, the pension gap, they both have an impact on the access of women to economic resources, which may be particularly damaging in older age when we are talking about women that live with less resources. And we know that life, and that's how we call actually our reports, that extra life expectancy is actually not an advantage, because women live in disability most of that time, and very much related to NCDs and to mental health. So how those social protection policies may encourage, not encourage, at least perpetuate that divide. In some cases, for instance, perpetuating the fact that women are kept into caring roles just because for cash benefits, or for perpetuating the payments to women taking up informal care. So we are making a call for attention of how it is that we are designing our home care models, how it is that we are designing the cash payments for informal carers, so that perpetuation of that being a feminized workforce is not there. And we are also looking at what it is the impact of gender stereotypes across the different life stages. And some of the determinants that are coming stronger into the picture are the commercial determinants of health. And we see it, for instance, in the European region, how the industry targeting young women has results, because we are one of the regions where in some countries this is increasing at higher rates. So how these gender stereotypes across different life stages may perpetuate that divide and that divide in outcomes. But an area where we are looking at also is that sometimes the health community itself perpetuates those stereotypes. And that's where we are also talking about gender transformative health promotion. And in some cases, we use what it is called an effective approach, when, for instance, we do tell young girls not to drink because they may get fat or get more wrinkles, but at the same time, that may have a side effect or a collateral effect on their mental health and well-being. So we are also challenging those stereotypes from that perspective. And the last point that I would like to make to keep within the time is that in many of we probably within the community will have to complement the good strategies that are known as the best buys, that do have a very strong impact on the risk behaviors. But when we unpack it from a gender and a social determinant point of view, we'll have to complement them with a specific actions that challenge those inequities and inequalities. Thank you.
Thank you very much, Isabel. Our next speaker will talk about NCDs and gendered access to healthcare. I've received a message saying she's not online, so I'm going to move on to Dr. Margie Pedden. She's going to speak on gender and injuries. She's a Senior Research Fellow, Co-Director, World Health Organization Collaborating Center on Injury Prevention and Trauma Care, United States. Dr. Margie, please. Dr. Margie, are you online? Okay, I don't seem to have a response from Dr. Margie. Maybe she's experiencing technical problems. I'm going to move on to the final speaker, Professor Anna Langer. She's Professor Global Health and Population Department and Director of the Women and Health Initiative at Harvard Chan School of Public Health. Over to you, Professor Langer.
Hi, everyone. Can you hear me?
We can hear you.
Perfect. Thank you so much. Thank you so much for including me in the Women and Health Initiative and in this important webinar. I will talk about a slightly different perspective that is very much at the core of our program at Harvard Chan, the Women and Health Initiative. Well, as we all know, women are affected by NCDs throughout their life course, but they are not only the bearers of NCDs, they are also the main caregivers of those who suffer from NCDs, often at the expense of neglecting their own healthcare needs. In most societies, caregiving is seen as a normal part of women's domestic roles. Girls and women provide care to children, acutely and chronically ill relatives, and people who are disabled or dying. But domestic healthcare providers are not trained, linked to the health systems, recognized or remunerated, as some of you have already mentioned. Their opportunities for education and generation of income are non-existent or interrupted when girls and women have to stay home and care for a family member. Their work represents an invisible subsidy to the health system, and a very large one. Community health workers on their side are overwhelmingly female, and their contributions are absolutely essential for the health and well-being of women and children, especially those with no easy access to healthcare institutions. Community health workers have a low status within the health system and are poorly connected with higher levels for referrals, supplies and drugs, training and supervision. Community health workers do not always get a salary or stipend, and when they do, the amounts are small, inconsistent, and insufficient. Nurses, most of them women, comprise 80% of the health workforce, but female nurses earn less than male nurses, even in the same discipline, and are often not allowed to practice up to their full capacity. The proportion of women physicians is increasing everywhere. These numbers do not necessarily translate into more influence of women doctors in the health system. Due to a lack of policies to support women to integrate their family and professional roles and to social expectations, female physicians are less likely than men to practice medicine once trained, to complete medical residencies, work full-time, or take leadership positions in clinical services. Women are critical members of the healthcare workforce, and they are very, very well positioned to help other women to successfully deal with the NCD burden. Strengthening women in the health workforce and narrowing the gender gap should be essential components of efforts to advance the women's NCD care agenda. For that, first, women have to be valued. This means ensuring women's universal access to healthcare that is responsive to gender and the life course, and also developing, implementing, and enforcing gender-responsive policies and programs to enable women to integrate their social, biological, and occupational roles and promote women's career advancement and leadership. Second, women have to be counted, and this is particularly critical for NCDs, a type of condition that women share with men. Sex disaggregation in health statistics should be one of the most pressing priorities everywhere, as it would allow us to better understand and act upon the gender-related differences in problems that women share with men. This is particularly essential to assess the true dimensions of NCDs among women. Also, research funding agencies, scientific journals, and development partners that support research should require that basic clinical, social science, and public health research projects enroll female subjects and disaggregate study populations by sex, and explicitly consider gender in their design, implementation, analysis, and reporting. Finally, women need to be fairly compensated. In other words, this means ensuring that men and women receive equal compensation for equal work in the health sector. In conclusion, women need to be supported as users and providers of care for NCDs, and gender disparities need to be effectively addressed so they become narrower and eventually disappear. These are public health and ethical imperatives. Thank you so much.
Thank you very much, Professor Langer. Dr. Rajani Ved has now joined us. She is the Executive Director, Ministry of Health and Family Welfare in India. I'd like to invite Dr. Rajani to give her presentation now. Rajani, floor is yours.
Thank you, Professor Mendes. Good afternoon, or whatever time of the day it is for everybody. It's a pleasure to be here with you all. Can the organizers please? Okay. So my presentation is going to focus a little bit on how do you integrate or reorganize health systems, particularly primary healthcare services, to accommodate NCD programs. And so I have two slides, and my first slide focuses on the challenges to PHC services. So the first point is really both a challenge and an opportunity for integrating NCD programs within existing platforms for primary health care. Currently, health systems in low and middle income countries are largely geared to the provision of reproductive, maternal, newborn child health services and largely focused on pregnancy, delivery, and family planning. However, as we heard from previous speakers, these are important opportunities for us to pick up future signs of non-communicable diseases, particularly hypertension and diabetes amongst women. But yet, we have very high levels of information asymmetry, particularly among women. That is a barrier to women accessing NCD screening services, such as they exist in low and middle income countries. There are also barriers among healthcare providers, and we've heard a little of that before, but particularly among frontline workers and the teams of primary healthcare on the possible association of non-communicable diseases in the different stages of a woman's life course. The focus of frontline workers has hitherto been largely on pregnant women and those within the reproductive age group. And a really big blind spot in the health system is that women beyond the reproductive age group are hardly ever addressed. So in countries like India, where early childbearing, even though it has declined, is still quite substantive, and sterilization forms the main form of family planning, women are really out of the health system at around the age of 30. And thereafter, which we know is a high-risk age, women don't enter the health system at all because the health system is geared towards addressing the needs of women during the reproductive age group, particularly for pregnancy and delivery. And we know this happens across different countries as well. Another major barrier is a lack of gender disaggregated data to allow policymakers and programmers to make decisions on prioritizing NCD services. And now I speak about contexts where fertility rates are declining, where the numbers of pregnant women and children needing care from the system are falling, but there isn't enough data on NCDs to allow programmers to design non-communicable disease programs on primary healthcare platforms. And another big problem is insufficient human resources to really address NCDs, because for the last 3 or 4 decades, healthcare training has all been related to reproductive health needs, and therefore non-communicable diseases have hardly been a focus. And finally, something that's really important for non-communicable diseases is primary prevention, and that gets short shrift, particularly because it needs a different skill set and an approach to multi-sectoral convergence, and there's not much understanding of that. I just want to focus a little bit on the recent India experience in adding non-communicable disease services at the primary healthcare level. It requires, one of our biggest learnings in the last year since this has been introduced in India is that it needs a lot of policy and paradigm shifts at multiple levels. Now, India has added a non-physician health worker to lead the primary healthcare team. We also have introduced a digital platform to enhance continuum of care, particularly focused not just on continuum of care for the individual patient, but also to use for teleconsultation and telementoring to support frontline workers at medical college level and at the district hospital level, so that providers get a sense of what is needed to be done so that patient hardship is minimized, particularly for women who don't have access to resources to move upwards in the system. There is a focus on primary and secondary prevention. Unfortunately, the focus seems to tend to be on secondary prevention because it focuses on medicines and therefore that seems to have become the primary focus rather than primary prevention. There's also been the recent introduction of performance-based incentives, particularly to focus on the achievement of gender equitable services that looks at gender disaggregated data, particularly for screening and treatment access. However, and one more thing is the role of frontline worker teams to increase their incentives when they reach more women for screening. Our recent experience tells us also that because the platforms for primary healthcare were created for women in pregnancy and delivery, screening seems to be much more for women. Of course, it's too soon yet to speak about this and before men start coming into the program. But as of now, women frontline workers who have had more access to women tend to be accessing them for screening for hypertension and diabetes. But however, we don't yet have a gendered policy for primary healthcare and non-communicable diseases. I'll stop here now. For some strange reason, the video that has Alisa's name on it, but my introduction was as Rajani. So thank you very much.
Thank you very much, Rajani, for sharing the experience in India, given that the NCD burden is practically 75% of it is in the developing world. So we have now Dr. Margie Pedden online to speak on the very important subject of violence and injuries. She is Professor Global Health and she's a Senior Research Fellow, Co-Director, WHO Collaborating Center on Injury Prevention and Trauma Care, United States. Dr. Margie, please.
Thank you very much, Shanti. Can you hear me now?
I can hear you.
Oh, wonderful. Thank you. I'm so happy that injuries have been included in this really important discussion. There's so many overlaps between some of the risk factors that are critical to begin thinking about with regard to injuries and violence and gender. So in the 5 minutes that I've been given, I just want to make 5 points. And I'm sure when you think about injuries and violence and gender, I'm sure the first thing that springs to mind has to be domestic violence, sexual violence, intimate partner violence. And quite rightly so, around 30% of us women around the world have been either sexually and or physically abused by one of our partners sometime during our lifetime. And so this is a really an important aspect and an issue that we really need to take seriously. And a lot of work is being done, led by the WHO and other collaborators. But think about some of the other types of injuries that have a gender aspect to them. And the first one that springs to mind is burns. Burns is the only type of injuries that actually has a female preponderance. All other types of injuries, road traffic crashes, poisoning, violence, etc., have a male preponderance, but burns has a female preponderance, both for mortality and for morbidity. Why is this the case? This is usually related to cooking practices. And in many countries around the world, cooking happens on open fires or using traditional stoves. And young girls, as young as 9 and 10, are taught to actually cook on stoves. Many of them wearing clothes which are highly flammable. And so there is a high propensity for burns amongst young girls and women. Sadly, also in many countries, there are honor killings that happen and suicides that take place as a result of self-immolation. So burns is an important gender aspect. And there is also the additional issue of indoor air pollution and relationships there with asthma. Falls, we're all getting old, and we women in particular tend to outlive men. And due to our osteoporosis, other comorbidities, we're very likely to fall. And when we fall, we very often fracture our hips. So a woman issue, falls particularly amongst the elderly. The fourth point I want to make is around what we call the gender paradox in suicide. And this is that women tend to think about suicide a lot. They also tend to sometimes attempt suicide, usually by taking less lethal means like tablets, whereas men are more likely to complete suicide. They're much more likely to commit suicide using a much more lethal means, such as a gun or jumping from high buildings. So there we have the gender paradox in suicide. And then the final point that I want to make, and it relates a little to the presentation that Alan White gave earlier, and that is injured women tend to have worse outcomes. And this goes beyond equity. Yes, there are issues around women's access to care and women tending to put themselves and their children, putting others and their children ahead of themselves, and so sometimes present late. But there are other issues around a woman's stature, for instance. Given the same mechanism of injury, women tend to have more severe injuries. And also the safety equipment that has been designed has traditionally been designed with men in mind. And just this week, there have been issues around crash test dummies and how the focus of crash tests has been on a male dummy and not on a female dummy. So in conclusion, I just want to say that we really do need to begin to think about injuries and violence and gender. The long-term effects of violence and injuries include things like depression, mental health, disorders, suicide attempts, unwanted pregnancies, STDs, HIV, etc. But there are proven intervention strategies that we know, which include working with perpetrators of violence, home and school-based programs, and some very specific interventions for falls and burns that can be tailored particularly for women. So thank you very much for including injury, Shanti. It's great and perhaps we should change the name to NCDs, but I just put that out there because I think injuries are an integral non-communicable disease. Thanks.
Thank you very much, Margie. You have extensive experience on this subject. I want to ask you, it appears that 49 countries lack laws protecting women from domestic violence. Is anyone doing anything about this within and outside these countries? It seems an appalling situation. Is there any naming and shaming going on at least?
Yeah, there's a lot of work that's being done. There's a coalition of UN organizations that are working together, WHO, UNICEF, UNFPA, and others. That are pushing the issue of domestic violence. But it's a sensitive issue, as you've mentioned. And governments have to be convinced that policies are the right way to go. In those countries that don't have policies, there are some prevention initiatives that have been put in place while politicians think about whether this is right or wrong. But I think that a groundswell, certainly from we women academics, would be very helpful as well.
Thank you, Margie. I want to direct a question also to Professor White and Keeling. Professor White, you explained the biological differences that drive response to treatment, and Dr. Keeling, you reiterated that drugs found to be effective for men in randomized controlled trials may not be as effective for women. So in relation to NCDs, what should governments and researchers do to close this gap? First, over to you, Professor White, and then Anne.
The need for research to be vigilant in reaching out to women. The reason why women were not included was because of the influence of the sex hormones, the risk of pregnancy, and also the more willingness of some young men to take the money and to be part of research. I don't know how we go about getting that change without better funding for research. We have to persuade researchers to have a more vigilant approach to getting women recruited onto programs and then running the trials to see the effect of drugs and drug therapies on both men and for women. It's a big problem, but we need to ensure that we now start to see changes in the way that drugs are prepared for sale.
Thank you. And you want to add to that?
Yes, thank you. Thank you, Shanti. I absolutely agree with everything that Alan has said. I think this also relates to drug companies. So it's not only governments and research, but there are steps that drug companies can take. And I think as Margaret was saying, this extends to safety equipment. We have a problem in the UK with our female police and stab vests, which are either too heavy for them or actually cause them injuries. So they're tending not to use them. So I think it's across the board, this idea that you can take men as the norm and then just extend what you've tested on men to women, and it's going to work, and it isn't. I think that women's groups and researchers here have a very strong role in lobbying governments, but also lobbying companies to get this changed.
Thank you both. Dr. Yodi, you presented the importance of social protection policies, particularly with regard to the European region. In 18 countries in the world, it appears that husbands can legally prevent their wives from working. And in 39 countries, daughters and sons do not have equal inheritance rights. These kinds of inequalities, are there European countries in these lists?
Well, I could not say whether there are Europeans and countries in this list. I can say that, I mean, the European countries are usually at the top of the gender formal equality in terms of legislation, but what we know is that there are many inequalities in practice, for instance, in terms of ownership of land. So when we look at household, it sometimes is masking much of the inequalities that we have within the household in terms of who is the one that owns, particularly we see it with women in agriculture and rural women, who are the ones that own the land, and what happens when in terms of inheritance. So even if there will be not many countries that will have formal inequalities, particularly those that belong also to the Council of Europe, which has 48 countries in our region, there are for sure many of the inequalities that are happening, even if the law is it calls for equal rights. And what we do know is that there are some provisions from social protection policies. Some of them are being very discussed these days in the European region, like issues of the distribution of parental leave, and how social protection and policies on encouraging men, and in some cases making compulsory for men to take part of the parental leave as a means of facilitating that women can take jobs, are not being seen by employers as the suspicious ones of taking time off, but that men are taking those parental leave compulsory also, and in some cases is being lost if they don't take it. So there are many of those. That's one of the areas, and the other one is the one I also mentioned in terms of how do we ensure that the home care programs, and how do we ensure that the cash benefits for informal carers are being done with a gender transformative mind, so that they don't perpetuate the fact that there are women that are taking the low paid job on informal care, while at the same time it's being recognized the reality of women doing that.
Thank you, Isabel. There's a question for Dr. Rajani from the audience. Has the digital divide hampered the ability to expand healthcare access to women, using technology in India. Rajani, could you respond to that? Rajani, are you online?
Yes, I am online. Can you hear me?
I can hear you. Yes, go ahead, please.
So it's a little too early to talk about whether the digital divide is helping women. Certainly for workers, wherever the non-communicable disease programs have been integrated into primary health care, it's made a big difference to healthcare workers in that they can communicate to the medical officers in the primary health centers and above, and data flows, particularly where maternal child health programs are more mature as far as digitization is concerned. It has certainly helped the women frontline workers. Whether it's actually helping women, I suppose indirectly, yes. But for workers, it's proven to be really useful.
Thank you, Rajani. There's also a question to Dr. Margie Peden. What are the preventive measures for avoiding injury due to cooking fire burns in low and middle income countries? That is to Dr. Peden, that question.
Thanks, Shanti. There are a number of interventions that we can have, that we can look at, and a number of organizations are already working on this. Not only looking at injuries, actually looking at across injuries and clean air. So developing clean cook stoves, for instance. But one of the most basic and fundamental things that can be done is to lift the stoves off the floor, because that's where they tend to be, the fires tend to be made on the floor with cooking, women sitting around the fire cooking. Children fall into the fire, people working around the fire, the clothing catches alight. So simply just lifting it somehow off the floor so that people are working at this sort of height level. But then also changing from fossil fuels to a cleaner cook stove will reduce both asthma and other indoor pollution issues and burns as a result.
Thank you. There's also a question to Professor Langer. And the question is, what is the one thing that women can do, women who are not in leadership positions, to help themselves and their colleagues to assume leadership positions? Over to you, Professor Langer.
Thank you very much for that question. It's not only women who need to make an effort to reach leadership positions. It's a matter of both men and women in the system. Basically, there is now a lot of attention on women leaders in health, and in particular in global health, and many recommendations about what can be done in terms of raising the visibility of the issues, changing policies, so a better balance between personal, professional, biological needs can be reached. Obviously, also introducing some flexibility in training programs, so women will be able to accommodate their needs during those very, very important years, their 30s, during which most women reproduce, and at the same time, that's when they get very often their training and start climbing the professional ladder. So there are a number of things that can be done and need to be done. There is no single bullet, but definitely we need to increase the number of women in leadership positions and overcome the gender barriers that prevent women in the health field to reach leadership positions. But it's something that in fact is an intersectoral program, or a multi-sectoral program, I should say. It happens in every sector.
Thank you, Professor Langer. There is a comment also from the audience, and that is regarding inadequate maternity leave, particularly in developing countries, and reduced opportunities for breastfeeding for the female workforce. Can you comment on that, please?
absolutely right. Maternity leave or limited or sorry or no maternity leave are problems in developing countries, but well, now I'm from Latin America, but now I'm based in the US, and I can see how my colleagues struggle with that. I mean, there is no maternity leave in many places here in this country, a developed one. So it's not a matter that only affects developing countries. And breastfeeding, absolutely agree. There is no opportunity, a good opportunity for women to breastfeed. And in many places, well, they don't have the flexibility in their schedule. The facilities don't include a place where they can be with their babies. There is social stigma associated with women breastfeeding in public. So there are, well, all the conditions are there to prevent breastfeeding instead of promote it. Those are perfect examples of things that need to be changed in order for women to be able to fulfill their potential and ensure the health of their babies, of course.
Thank you very much. And at this stage, I would like to go around the panel for one final message, a very short one final message. And I want to start because we only have a couple of minutes more. And before I conclude, can we go around starting with Anne, one final short message?
Thanks, Shanti. I think the important, I think my message is that, you know, we've been working on this for a long time, but this community of practice is going to be a place where we can gather experience together, and that's what we've done today. So I think this is going to be a very powerful place to get these messages across on Women and NCDs. So thank you for organising it.
Professor White?
Two main audiences need to be really aware of all this. One is women themselves, and women you tend to find have got a whole raft of issues which are just absorbed within their life, and they need to be realized. They need to realize that how important these are, and how we should be working with them to be able to create change. And the other is with practitioners and politicians, to get them to really understand what human rights are and what gender equality is, and how important it is for both for men and for women.
Thank you. Dr. Homer? Caroline?
Thank you. Yes, agree with everything said so far. I think this community of practice is really important to get the message out there that Women and NCDs has a whole lot of new issues and old issues that we haven't been listening to. And for me, it's around thinking about the conditions that happen in pregnancy are not just pregnancy conditions. They have lifelong impacts, lifelong issues, and we need to always have those conditions and asking women whenever we see them across the life course about their pregnancy and their childbirth experiences.
Thank you very much. I'm afraid I don't have time to take the messages from all the speakers. Ladies and gentlemen, let us conclude before I hand over to Elisa, this discussion on a positive note. Let us remember that one of the goals of the 2030 Sustainable Development Agenda is to achieve gender equality and empowerment of all women and girls. The Sustainable Development Agenda is accepted by all countries, applicable to all, and is being implemented. But we must remember that there are gender gaps across all 17 SDG goals, including Goal 3 that we discussed today, which is health and well-being. So if there is gender responsive implementation of the 2030 Sustainable Development Agenda, it provides an unprecedented opportunity to address women's issues, particularly NCDs, and also to create a fairer world for both women and men. So as we conclude this discussion, I want to thank the speakers and all of you for setting the scene for future webinars on women and NCDs. It is a very important subject at the heart of human rights. We hope that all of you will continue to enrich future discussions. With that, let me now hand you over to Elisa for final comments. Over to you, Elisa.
Hi everyone, my name is Alyssa Chase Vilches. I am the UK Program Manager for the George Institute's Global Women's Health Program. I'm extending a very warm thank you to Shanti for her excellent job moderating today, to the WHO for all their support, and of course to our speakers, especially those who are joining us at very antisocial hours, either very late in the night or early in the morning. I also wanted to add that the conversation is not going to end here. Please do join us. We have a community page on the WHO's Knowledge Action platform. You can find us in the community section, and there we will be posting a recording of this webinar, and you will also have an opportunity to post comments and questions and to share valuable resources. The messages that were communicated today during the webinar by our presenters, both during their presentations and during the question and answer session, as well as the forthcoming conversations that we will anticipate will happen online on that Knowledge Action platform, will be shared widely. So as we mentioned earlier, on 19th of March, the George Institute will be co-hosting an event at the Commission on the Status of Women in New York City, and we hope to take some of the key messages with us there to spread widely. We'll also be creating short podcasts of the presentations that you heard today, and we'll be working with the designer to develop a visual graphic that will highlight the key factors that account for why women experience NCDs differently than men, why they have different risk factors and different outcomes. And we will be using these as part of our effort to share our message in New York. And we will also be spreading these with you so you can help disseminate this message further. Our next webinar will be held in June to coincide with the Women Deliver Conference. There we'll be discussing maternal health and NCDs, and we'll be sharing more details about this soon. And finally, I just want to say again how grateful I am for all of you for joining. We had over 100 participants this morning. We are aware that there were some technical difficulties that due to unforeseeable circumstances, Zoom wouldn't allow some people in. But again, we will be sharing this presentation on our Knowledge Action platform, and we hope that everyone will have access to it. We look forward to continuing the conversation online and at future webinars. And I hope everybody has a great day or night, depending where you are in the world. Thank you.